اسمي سامر Abu-Sultaneh. Originally I'm from here, so
خريج التكنو.
أنا خريج التكنو سنة 2003. دكتور Khalid, many of you guys were my teachers, so thanks for the invitation. Today I will talk about diabetic ketoacidosis. It's a very common emergency in the pediatric ward. I will talk about the definition of DKA, then talk about the pathophysiology. I think it's very important to understand that. Clinical presentation, then management and complications. So let's start with the case. Previously healthy 2-year-old present to the ED with hypernatremia, hyperkalemia, acidosis, and hyperglycemia. NN gap was 20. You can see that the patient has metabolic acidosis. So does this patient has hyperglycemia or DKA? So when you diagnose DKA, you should have three things. You should have hyperglycemia, which is glucose above 200, acidosis, which is pH below 7.3, or bicarb below 15, and you need to have ketones, whether it's in the urine or in the blood. You can subdivide then the DKA in the mild, moderate, or severe DKA. So you need to have the three things. You need to have ketosis, acidosis, and hyperglycemia, and you need to exclude the other causes of the ketosis, the acidosis, and hyperglycemia. There is always confusion about the other causes of acidosis. We see a lot of kids coming to the PICU or to the ED, and they diagnose them at DKA, but actually they have other causes of metabolic acidosis. As you know that DKA is non-anion gap, non-osmolar gap acidosis. So uremia, DKA, iron ingestion, lactic acidosis, and salicylate ingestion can cause that too. So why DKA happens? This is back to medical school. So you have, okay. I think I'm playing too much with it. Too much fast. Okay. So you have deficiency in insulin, and then you have an infection or stress. This can lead to lipolysis, which can produce your keto acids. The glucose intake will be reduced, so you have hyperglycemia, and again, from proteinolysis, you can have hyperglycemia. Then the glucose will go in the urine, and it will drag with it the sodium, the other electrolytes, and the water too, causing dehydration. Okay, so how these patients present? Usually they present, as we know, polyuria, polydipsia, polyphagia, nausea, vomiting, abdominal pain. Also, they can present with altered mental status. When we examine them, usually they have signs of dehydration. Rarely we see kids that they present with shock. They usually be tachypnic, and they might have altered mental status. They also have, other than the electrolyte that I mentioned, they can have hyponatremia, and you need to correct your sodium based on that formula. Their sodium, other than sodium, the potassium will be usually, when they present, they might be hyperkalemic, or they might be normokalemic, but the total potassium will be down. Other labs, usually with the loss of the other electrolytes, sodium, potassium, phosphorus, magnesium, they can have high white blood cell count, but if they have any fever, you need to suspect infection. The high white blood cell count is usually related to hemoconcentration. So how we manage them? The basic principles are, you need to diagnose the DKA, you need to replete them with fluid, and you need to give them insulin, and then you need to monitor them, make sure that you don't correct it very quick. So let's start with fluid. It's simple. They are dehydrated, 10 to 15% dehydration. We need to be very cautious when we treat their dehydration. So you don't like to do it very quickly, because you can create problems. So basically what you do is you start them in some isotonic fluid. Usually we start them in normal saline for the first 4 to 6 hours. Then after that, you add some dextrose to the fluid. You don't like to correct them very fast. So usually we put them on 1.5 maintenance, and then we observe their vital signs. We use at Riley, and I think in many US places, they use this two-bag system. So they have what they call solution A, that is a normal saline usually. Then solution B is a dextrose-containing fluid. And then we weigh them in, and initially when the glucose is high, we just start with a normal saline. Then when their glucose drops below 300, we start adding the D10, so we do 50-50. And if the glucose drop, we start increasing the D10 normal saline so we can give them more glucose. So this is just a couple of examples of the solution A and solution B. Usually you don't like to add your potassium until your potassium is below 5.5. So is this two-bag system is beneficial? So there was a study done, as you can see here, very small sample size. But what you can see, the most important thing is the number of bags will be decreased here. And the most important thing is the response time. So instead of waiting for about half an hour to wait for the fluid to come from pharmacy, the nurse can change it very quickly. So the response time will be 7 minutes. So very quick. You don't lose a lot of bags. You don't lose money with that system. Now, we talked about the normal saline. People talk about now using what they call balanced fluid, because one of the problems during treatment of the DKA is hyperkalemia. We can have hyperkalemic metabolic acidosis, and that can delay our treatment. So this is one study that they did here, and what you can see here is when they use a balanced fluid, their chloride level was lower, and the bicarb level was higher. Now, what about insulin? You need to give them insulin. We don't recommend giving any insulin boluses. So if you need to treat DKA, you wait usually about an hour before you give them any insulin. Then you start them on an insulin drip. The usual dose is 0.03 to 0.1 unit per kg per hour. We use a lower range of the doses, especially for younger patients. This is a study that was done, compared the 0.03 to the standard dose, which is 0.05 to 0.1. And what they found that their correction for the hyperglycemia, it's about the same. Their pH, bicarb, and also anion gap were about the same. So they are both effective, whether you use a lower dose or the standard dose. Now, do we give bicarb? So I don't know about adult guidelines, but usually in kids, usually we don't give any bicarb. It can cause more complication. It can cause cerebral edema and paradoxical CNS acidosis. The other thing that, other than fluid and insulin, you need to monitor your patients. You need to monitor their neurostatus every hour because they are at risk for cerebral edema. You need to monitor their glucose because you don't like to drop their glucose very quick. So our goal is to drop their glucose by 90 to 100 every hour. You check their electrolytes because there is usually a very big electrolyte shifts with your treatments. So usually we check them every 2 to 4 hours. Now the MAG and FAST, usually we check them every 4 to 8 hours. Now, when do you transition from an insulin drip to a subcutaneous regimen? Usually when the DKA is resolved. Usually your pH is above 7.3, your CO2 is above 15. You give them the long-acting, which is the Lantus, and then short-acting. And there is two things with the short-acting. There is a carb-correcting, and there is also glucose-correcting dosing. And usually our endocrinologists are better than us calculating these doses. Now let's talk about the complication. I will spend a few minutes about the cerebral edema. And the most important thing about the cerebral edema that we can cause cerebral edema. So the risk is about 0.5 to 1. The mortality is high, is about 20% mortality. It can cause permanent neurological disability if you survive from the episode of cerebral edema. Usually it happens within actually the first 24 hours. And most of the time, when I talked about fluid, we are cautious in the first 4 to 6 hours because it can happen actually in the first 4 to 6 hours. The pathophysiology is very complex. We think that what happens is rapid fluid shift, but also there is also some cytokine release causing some endothelial damage. Also with the rapid breathing, you can decrease your CO2 and decrease the perfusion to the brain. So some of the things that we can control that we should always do, which in our treatment we should correct these kids slowly, but some of the kids already come with some degree of cerebral edema to our ICUs. So risk factors, as you can see, usually they are younger age, severe DKA, first time DKA, and lower CO2 and high BUN. And for our treatment, the things that we can cause is if we give them bicarb, well, I always like to end my slides very early. So if you give bicarb, if you correct them very quick, if you drop their sodium, or if you give them insulin within the first hour. So usually we try to avoid the insulin until we give them some fluid. This is again the risk factors. Most of these are because of us. We drop the sodium very quick, or we don't react to the sodium. We give them too much fluid. And people cite this number, which is 4 liters per meter squared per 24 hours. So if you calculate it, if you start the patient on 1.5 maintenance total fluid, you should be always safe when treating DKA. Now, the signs and symptoms, most of our kids comes with altered mental status and headache or nausea and vomiting. Rarely we see patients that they actually have a neurological deficit. So you can have one diagnostic criteria, 2 of the major criteria, or 1 major and 2 minor. And I would say most of the kids that they don't die before they come to us, they come with this, 1 major criteria and 2 minor criteria. So altered mental status usually, and whether headache or vomiting related to cerebral edema. So how we treat it? We treat it as we treat any of the cerebral edema usual way. So we give them mannitol or 3%, and this is the doses that we use. So we use 0.5 to 1 gram of mannitol, and we give them 3% hypertonic saline, and usually it's 5 to 10 ml. We elevate the head of the bed, and after we manage it acutely, we do CT. CT is not that sensitive, and then we intubate them and control their ventilation. The other minor complication that can happen with us is the hypoglycemia, and usually it's easy to correct. Usually we increase their dextrose, sometimes we give them insulin boluses, and sometimes we give them glucagon. But most of these kids, the hypoglycemia is mild, and usually we treat it with increase of the dextrose solution. So, take-home messages, DKA is very common, it's a life-threatening, and most of the complications happens because of us. So you need to be slow and steady. Don't give them bicarb, don't give them too much fluid, don't give them insulin boluses. They will correct, even if they look very bad with altered mental status when they come to your ED or the ICU. And thank you.